Good morning, good afternoon, and good evening all. A very warm welcome on behalf of the IAPB events team. We very much look forward to supporting you today with Strengthening Capacities and Technical Acumen webinar series, with today's webinar focusing on integrated people-centered eye care. I'm now delighted to hand over to Dr. Ravilla to welcome you to the webinar. Thank you.
Thank you very much, Roz. So good morning, good afternoon, and good evening to everyone who has joined this, what I hope will turn out to be a very informative webinar. I personally am very much pleased that this particular topic was chosen, and I was asked to chair it, because I very firmly believe that solving the problem of avoidable blindness, and visual impairment, while we need clinical acumen and resources and everything, it also boils down to the right design. And this whole notion of integrated people-centered eye care is largely around getting our design for eye care right. So from that perspective, I hugely appreciate the impact of this. And then this is, I think, proposed for eye care in general, and I think it's come out of recognition of certain chronic problems that we have been having in eye care for decades. For instance, I think what is listed in the World Report on Vision are some challenges, saying that eye care services are inequitably distributed. That means there are a lot of inequity in the availability of services of very varying quality, and which is of great concern. And it's poorly integrated across related health programs and sectors, and even beyond healthcare. And whatever service that are provided are often uncoordinated, and also by unregulated workforce. In the sense, it doesn't really imply untrained, but then I think other than ophthalmologists and optometrists, the rest of the cadre is not really been accredited workforce, at a national or regional or global level. So on all these fronts, I think there is an urgent need for redesign, and which I think is the intention of the integrated people-centered eye care approach. And I'm really excited that we have 4 experts who will be presenting. And we have, again, a distinguished set of panelists who will be kind of dissecting the presentations afterwards. And I think this will be also enriched by the 80+ participants who have signed on and attending it as of this minute. So what I propose in terms of format is that I'll introduce each of the speakers just before their presentation. So there are 4 of them. So in total, that may take on an average of 10 minutes. So we should be done in about 40 odd minutes. After that, we will have an open discussion. We have 5 panelists, whom again I'll introduce at the time of starting the panel discussion. We will start off with certain questions that I'll pose to the panelists, and then open it out to the to people's questions. And as Ross said, we really encourage you to post your questions in the Q&A chat box, and I'll probably request our friend YD to prompt me with the questions as they get posted. So without much further delay, let's start the webinar and hear from the experts. Now, to start, Dr. Rohit Khanna, who's the director of Gulapalli Pratibha Rao International Center for Advancement of Rural Eye Care, what they call as eye care unit of LV Prasad, India. So he would talk about the overview of integrated people-centered eye care, so that we get the broad picture. So on to Rohit's presentation.
Welcome everyone. In this lecture, I'll give you an overview of what we mean by integrated people-centered eye care. Recently, the World Report on Vision came out with significant facts. One of the facts was everyone, if they live long enough, will experience at least one eye condition in their lifetime, either blinding or non-blinding. It also came out with the fact that at least 2.2 billion have visual impairment and at least 1 billion have visual impairment that could be prevented or easily be treated by simple means. On the right side, there are some of the conditions which are blinding or can cause visual impairment. The most significant among them are uncorrected refractive error and presbyopia, followed by cataract. It also came out with some projections of some chronic conditions like glaucoma and age-related macular degeneration. The projection was that at least by 2030, there will be 243.4 million with age-related macular degeneration and 95.4 million by glaucoma. If we don't do anything, these numbers are going to increase exorbitantly. It also stated that the cost of treating the most common blinding or visually impairing eye conditions like cataract or refractive error is US 14.3 billion. So an investment of US 14.3 billion can take care of the existing problem of unaddressed refractive error and cataract. It also came out with significant fact that most of these blinding conditions or condition causing visual impairment are in low or middle income countries. People living in low and middle income countries are 4 times at higher risk than high income countries for these kind of conditions. It also stated that the significant risk factors include people, those living in rural areas, those with low incomes, that is low socioeconomic status, women, people who are aged, people with disabilities, ethnic minorities, and indigenous populations. Most of these eye conditions are due to some of the risk factors which are either modifiable or non-modifiable. The non-modifiable factors include age, genetics, ethnicity. You can't do anything about your age. Everyone is going to age over the period of time. Genetics are from your parents, so you can't do anything much about it. But there are certain factors which can modify it. It includes the lifestyle factors like smoking, nutritional status, occupational and recreational activities, environmental related factors, and so on. Over the past 20 years, there is a lot of achievements as far as eye care conditions globally are concerned. We have done a good amount of advocacy through Vision 2020, which is in collaboration with IPEC and World Health Organization. We have good amount of success stories for vitamin A, trachoma, onchocerciasis, and there are good cataracts success story from countries like India. We have also developed models for eye care in developing world, and in technology and science we have advanced quite significantly and came out with new therapies, new innovative ideas. There are effective interventions available for eye care, for health promotion, prevention, treatment, and rehabilitation, which can address a range of eye conditions which causes visual impairment throughout the course of your life. Some of these interventions are very cost-effective and very feasible. However, to take this intervention to the last mile, there are major issues like issues related to availability of services in these regions, accessibility, and acceptability. Apart from, there are issues with eye care sectors like its labeled as having a very vertical program. We have lagged in coordination with the private sector, and we don't have a regulated workforce. In many countries, optometry is not even recognized as a profession, and we are not a part of the entire health information system. So we are labeled as a very, very vertically driven structure in the entire health system. So moving ahead, learning from the past stories of vitamin A, trachoma, onco, and moving ahead to future, we need to think what needs to happen so that we can take care of the problems like cataract, uncorrected refractive error, other chronic eye conditions, non-blinding eye conditions, and so on. So some of the recommendations by World Report on Vision was make eye care an integral part of universal health coverage. Implement integrated people-centered eye care in health system. Promote high-quality research. Monitor trends and evaluate progress. And raise awareness and engage and empower people and communities. So one of the way to achieve integrated people-centered eye care is through universal health coverage. What is integrated people-centered eye care? It is for the people. That means they receive a continuum of health interventions which starts from promotion, prevention, treatment, and rehabilitation. It addresses the full spectrum of eye conditions. It's coordinated across the different levels and sites of care with and beyond health sector, and recognizes people as participants and beneficiaries of the service throughout their life course. So ultimately, it is for the people. And if you look at the box of universal health coverage, it says that services should be provided to each and everyone at a low cost or at a reasonable cost. And if we achieve universal health coverage, we will achieve most of the agendas for sustainable development goals, including the goal 3, which is ensuring healthy lives and promote well-being for all at all ages. WHO also came with framework of integrated people-centered health service, and it has 5 strategies. Strategy 1 includes empowering and engaging people and communities. That means ensuring that people come for regular eye examinations, services are available to them, and they also comply with medication. One of the good examples for empowering and engaging people and communities is seen in onco programs. The Onco program was quite well designed in a way that it empowered communities to ensure that this condition is eliminated as a cause of needless blindness. It also says that you have to reorient the model for care. We need to use innovative models for care to strengthen eye care in universal health coverage and ensure adequate workforce is available who are well trained, there is adequate funding, and there is effective referral system plan. It also ensures that care is provided by a team, there is a good referral system, good linkages, and each case is managed based on the efficiency at each level of eye health pyramid. So it's up and down, it's moves from up and down. People you see in the community are referred to the primary to secondary or tertiary, or sometimes directly to tertiary or secondary, and vice versa. So that flow of referral chain system and that coordination across different levels of care, including different systems, different health sectors, is required if we want to achieve our goal of integrated people-centered eye care. At the end, it also asks for creating an enabling environment. That means strengthening the 6 building block of health system, starting from leadership and governance to service delivery, which will lead to improve health and improve efficiency, improve quality, and good health for all. To conclude with, it is not necessary that everybody has to start at one pace, There are countries may have different starting points for implementing the strategies, and it all depends on the maturity of the system. For example, countries like the United Kingdom, which has a good national health system, NHS, which has a good referral system, which is working very well. Some countries may be in a primitive stage of starting this kind of system. Some countries may have established, but implementation is an issue. So we have to, each country has to decide at what stage they are and start planning how do they go and achieve universal health care and achieve the goals of sustainable development and ensure that we provided integrated people-centered eye care, which is for the people. And would like to thank you for your attention and time. Thank you very much.
Thank you, Rohit. That was a very comprehensive overview of this emerging strategy of integrated people-centered eye care. And then you covered a lot of ground. I think there'll be a rich opportunity for discussion following the other presentations. I would also repeat the request to all the participants who exceed 100 now to start typing in the questions. I would really encourage you to start doing it during or immediately after each presentation, so that we are not directing all the questions at the last presenter. Now, moving on to the next speaker, Dr. Sri Priya Krishnamurthy. She is with the Medical Research Foundation, Shankar Nethralaya in Chennai. And she's going to be talking on an important aspect of quality, because this has come up time and again. And in fact, in the World Report for Vision, I think one of the concern which underlying this particular strategy is around unequal quality, which means probably a diplomatic way of saying is that the quality has got to kind of improve overall. And so to talk about that, we have Dr. Sri Priya Krishnamurthy, and on to you.
Quality eye care and IPCEC. Quality eye care is when it is affordable, available, reliable, equitable, trustworthy, and universal. The aim of IPCEC is to deliver quality care to the masses with their participation in a sustained and comprehensive manner, strengthening the governance by coordinating across the sectors of health, education, and labor, thereby creating a favorable environment for patient care. A system is efficient if the care is effective, accurate, and timely. It can be delivered only if the safe check systems are in place and cannot occur unless it is people-centered with their participation. Participation builds trust and sustainability. Health awareness improves participation, which can be achieved by integrating the sectors. The first barrier to eye care is the lack of benchmark or indicators for quality. Indicators need uniformity, which is impossible due to variations in terrain, disease pattern, disease magnitude, population density, and also because it varies based on the perception of the perceiver. The people look at quality as a care that is available and accessible to them, while the medical world will look at it from the quality of the care delivered to the masses. The facilitators or the administrators will evaluate quality based on the growth outcomes and sustainability of the program in the form of equipment, funds, or maintenance. To bring about quality care, the WHO, IAPB, and the international agencies have devised strategies for incorporating the eye care with the public as integrated, patient-centered, comprehensive eye care. The IPCEC aims at handling the issues in 4 ways. First is empowering the community. The present hurdles for universal health care include under or improper utilization of the existing health systems, multiple parallel programs under different bodies, inadequate infrastructure, lack of motivated manpower, access, awareness, and also referral links. The concept of utilizing the existing manpower in the system has improved the access to comprehensive eye care. For example, the ophthalmic assistant in the villages treats minor ailments but also teleconnects for specialist care at a tertiary center. The Asha and the Anganwadi workers in the villages of India spread awareness among the rural population. When in Africa, the treatment of onchocerciasis with ivermectin was shifted to the community in 1995, the disease declined dramatically from 73% to 14%. The increase in diabetic retinopathy detection rates from 9.45% to 63.8% was possible with the use of mobile screening at the village level. The improvement in cataract surgery rate in rural China by increasing the people awareness is also a reflection of the power of engaging people. The reach of eye care can be far and wide with integration of the eye care with the existing healthcare system. To balance the rural and urban mismatch, India has a structured referral program involving the community health worker in the village who can refer to the subcenter for minor ailments and to the vision centers or the tertiary eye care center for higher level of care. This is well reflected in the multi-tiered system of eye care in the country, with the workers at each level having a well-defined work pattern as well as the necessary infrastructure and interconnectivity. This may not be the case in all countries and can be considered for implementation. When the village health guide is made to conduct screening camps and distribute glasses, there was better public participation and better use of the existing healthcare systems of that area. These measures help cover large rural areas with benefit for more. One of the greatest hurdles to quality care is the lack of coordination between, within, and across healthcare systems and different public sectors. This is the next aim of IPCEC. The tertiary referral center should be within a feasible distance of the patient to be effective, with good links between them and the PEC. When the neonatal care was linked to the ophthalmic care, there was a 38% reduction in the number of children with ROP cases in Argentina. This is a classic example of inter-health system coordination. A session on ROP and squint, including the risks and consequences of delay in CME programs for obstetricians and pediatricians, will facilitate timely referral from them. For awareness to reach the grassroots levels, facts on first aid measures for eye injuries should be incorporated into the school and college curriculum itself. Women's eye health is an example of the reduction of trachoma by integrating the different health systems. School screening results must be directly linked to the health authorities, and the health industry must be the top priority of the labor industry. The last and the most important part of IPCEC is to create an enabling environment of leadership and governance involving better information systems and workforce. Leadership and governance. A central governing body is essential to maintain population data and surveillance, share information, and avoid reduplication of studies and investigation. We need a shift from quantity measures to quality scores to evaluate the effectiveness of interventions. Central regulatory bodies are then needed to maintain equitable care. Health Information Systems, or HIS, is essential for creating a benchmark for disease magnitude, assessing the implementation for utilization of services, initiating appropriate quality care, and helping the health sector plan the funding for intervention. Electronic medical records, EMR, needs to be introduced for maintaining quality, transparency, and to transfer information from the peripheral centers to the higher center and vice versa, so that care will continue once the patient is back at his rural center. Both HIS and EMR will give us a universal database for disease magnitude. This will aid planning healthcare allocation of revenue as well as manpower with far-reaching benefits. The entire system is anchored by the workforce in the field. Because of improper distribution between the population and healthcare providers, the primary healthcare worker is pivotal to achieve universal healthcare. The lack of equipment, feedback, reviews, compensations, teamwork, recognition, and appreciation are the major reasons for attrition of the workforce. Studies have shown that regular retraining of the health worker and the supervision of their work by regular visits will maintain the motivation of the worker. Once or twice a year, they need to be welcomed to the secondary center to recapitulate what they know or to learn a new skill. The gradual enhancement of their skills over time will maintain better retention of knowledge and manpower and deliver quality care to the people. To improve the access to eye care, mobile medical as well as surgical units need to be created. This reduces the need for additional training, manpower, and infrastructure, and also engages the people in their own eye care. The novel concept of a mobile surgical unit, which can be assembled in the villages, have shown to give excellent quality surgical care and results. Without quality checks, no programs can stay on track, and it's time we incorporate quality as well as quantitative benchmarks from primary to tertiary level of health system. Simple Likert scales can be used for questionnaires for patients. Regular annual evaluation by external agencies at the field will help assess the quality of the intervention as well as the effectiveness and appropriateness of it. Data analysis comparing the surgical interventions against the population-based study data will be a check at the tertiary level for comprehensive care. To maintain interest and motivation, skill updation and recognition are equally essential. To summarize, quality care is shifting from primary eye care to primary health care with coordination between different sectors of health, education, and labor. Creating benchmarks of quantitative and qualitative care from grassroots to tertiary care level with regular course correction based on customer feedbacks and audits, and encouraging the health workers by regularly updating their skill, certification, and recognition is the way forward. My colleagues will share their experiences on the hows and wherefores. Thank you.
Thank you, Dr. Sripriya, for this possibly the most comprehensive definition or framework for quality and covering all aspects of it. I'm sure this is going to generate a fair bit of questions because there are lots of areas which we really haven't considered as quality in the past, wherein we put on our blinkers, looked at only clinical outcomes, or at best patient feedback and patient experience. But now we have talked about coordination and equity and many, many other issues. So once again, requesting the attendees to post their questions. Now would like to move on to the third presenter, Ms. Divya Ravilla. She's going to be talking about integrating people-centered eye care at primary level. I think this is an important topic because in eye care, by and large, primary eye care is just emerging. Even though the general wisdom is that primary level care is what really brings in people into eye care, and in a both timely and in a timely and as well as giving a high level of coverage as well. But for some reason, eye care for long has been a curative discipline with secondary and tertiary care that's slowly being addressed now. So she's going to be talking to us about integrating people-centered eye care at primary level. On to you, Divya.
Hello, I'm Divya Ramasamy from Aravind Eye Care System. In this session, we discuss the design of primary eye care services and how they can help achieve people-centered care. Primary eye care centers have the unique advantage of being within the proximity of those who need care. We will see how we can leverage their local presence. We will also explore effective primary eye care service design and how this can be integrated within the larger framework of people-centered care. At the primary level, it is finally possible to discuss coverage of eye care needs because we are talking about a finite service area and population. Rough estimates will tell us that for a population of 75,000 people, we will need to perform at least 675 cataract surgeries per year. At least 15% of the population will need spectacles, and 1% of the population will need long-term glaucoma care. All the diabetics in the population will need to be screened annually for diabetic retinopathy, and those with DR will need ongoing monitoring. So roughly 25% of the population will need some form of eye care. Primary eye care centers or vision centers need to be designed to meet this need. Vision centers are responsible for the eye health of the population they serve. In order to be truly patient-centric, they need to be full-time permanent facilities so that patients can seek care whenever they choose to. Vision centers cannot be limited to refractive services or cataract referral alone. With standard clinical protocols and technologies such as fundus photography, digital tonometry, these centers can provide fully comprehensive eye care. They should be equipped to provide first aid for emergencies. And it's important to have teleconsultation for all patients. The ophthalmologist can then confirm the technician's findings and prescribe the treatment in order to ensure quality of care. This is made possible with cloud-based EMR systems that are simultaneously visible to the ophthalmologist. And because a prescription alone is not going to do the patient any good, vision centers must create access to spectacles and drugs in order to close the service loop. One of the most important things that vision centers can provide is follow-up care. Compliance to follow-up visits has been reported to be higher among vision-centered patients. In addition, field workers or volunteers can reach out to patients in their own homes to ensure compliance to treatment. These centers are also best positioned to ensure long-term care and monitoring for patients with chronic conditions. We find that these vision centers play an important role in addressing all eye care needs of the community. This chart shows the proportion of ocular conditions diagnosed at the vision center. With vision centers providing comprehensive care, less than 10% of these patients need to be referred to higher levels of care. The vision center model is proving to be effective in terms of achieving coverage. In about 15 years, over a fifth of the population in the service area of Arvind's vision centers have visited these centers at least once. We must now break this down to see if we are comprehensively addressing each condition. We estimated about 1% of the population will need to be covered for long-term glaucoma care. Now, about 15,000 patients with glaucoma are registered at these vision centers. An estimated 3% of the population has diabetes. Over 50% of the diabetics there are registered at these vision centers. And of these, over 12,000 patients who are diagnosed with diabetic retinopathy are under long-term monitoring at the vision centers. Roughly 1 in 5 persons in the population would need a pair of glasses. About 1/3, that is 400,000 spectacles, have been purchased at the vision centers. For cataracts, a cataract surgical rate target of 9,000 was set. Currently, the vision centers are able to achieve a CSR of 3,600. This shows how vision centers pave the way towards achieving universal eye health. The local presence of vision centers make them really people-centric. During the lockdown in India, transport was severely restricted and patients were unable to travel to eye hospitals to receive care. However, as vision centers were reopened, the patient volumes rapidly returned to normal, even while our larger hospitals had very few outpatients compared to normal days. Even in situations where travel is challenging, Vision centers are able to be responsive to the community's needs. Such vision centers can and have been successfully integrated into the existing government health system. Since 2007, the government of Tripura has been successfully running over 40 telemedicine-enabled vision centers that provide comprehensive eye care to the remote parts of the state. Similarly, the government of Bangladesh has committed to set up 400 to 500 vision centers, one in each Upazilla or sub-district. These community vision centers are integrated into the Upazilla Health Complex. So far, over 90 centers have been set up and are operating successfully. Vision centers can also be successfully integrated with private sector hospitals. This is an example of one of BRAC's vision centers that has collaborated with an NGO hospital to provide teleconsultation and cataract surgery services. Several hospitals are also experimenting with engaging local optometrists to provide comprehensive care and referral services. By engaging well-trained and committed optometrists and ensuring proper coordination, comprehensive primary care can reach the local population. And this model can be a big win-win for both parties. For primary eye care to be truly people-centric, it must be available on demand. Service design must consider patient convenience, and service must be reliable and of high quality. The care cannot be restricted to just cataract referral or refractive services. The care must be comprehensive. The care loop must be completed. Spectacles, drugs, access to higher levels of care, all of these must be made available and affordable. This integration between the different levels is important to ensure continuity of care. The recent Lancet Global Health Commission recommends this framework for integration of eye health services within the healthcare system. According to this framework, primary eye care services must be integrated with NCD services for screening diabetics for DR, integration with child health services and school screening, which has traditionally been done by tertiary and secondary care hospitals, must now be integrated at the primary level to be truly effective. Vision centers must engage their communities through health promotion to improve awareness and health education. When vision centers are deeply rooted within their communities and at the same time well integrated with secondary and tertiary eye care services, then the care becomes truly people-centric. Thank you.
Thank you, Divya, for this, what I would say, evidence-based presentation on the primary eye care and how it can integrate with the people-centered eye care, as well as what needs to be done, and the traction it's already having. Thank you very much. Now moving on to the last presentation, which will be done by Dr. Rachna Mir. She is with the RP Center, which is part of the All India Institute of Medical Sciences. She'll be talking about an important aspect of any program, which is monitoring indicators for IPCEC. This is of particular importance because even a mature ongoing program requires constant monitoring to make sure things are working well. And when we are trying to do something new, this achieves paramount importance, because when you're experimenting, when you are breaking new grounds, you really need to know if things are going on well. So she has come forward to talk about this important topic of monitoring. So now on to you, Dr. Rachna Mir.
I will be talking about indicators for monitoring IPCEC. IPCEC, or Integrated People-Centered Eye Care, refers to services that are managed and delivered to ensure a continuum of promotive, preventive, treatment, and rehabilitative interventions against the spectrum of eye conditions coordinated across the different levels and price of care within and beyond the health sector and according to their needs throughout the life course. IPCEC has emerged as an important means to achieve universal health coverage. Universal health coverage means that all people have access to the health service they need when and where they need them and without any financial hardships. Integrated eye care is essential to address the challenges arising from changing demographics, inequities in access, and lack of integration, and therefore it needs to be an imperative part of UHC. IPCEC can contribute to achieve universal health coverage and also Sustainable Development Goal 3 of WHO, which is defined as ensuring healthy lives and promoting well-being for all at all ages. SDGs or Sustainable Development Goals are the targets for priority areas of action that all the United Nations member states have agreed to achieve by 2030. Integrated eye care services are important for achieving targets of Global Action Plan, specifically target SDGD 3.8, which is to achieve UHC, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Effective integrated eye care will also contribute to other targets such as those on neglected tropical diseases, mental health, road traffic accidents, and workforce health. What this means is that while implementation of IPCEC will significantly contribute to achieving the target of universal health coverage cannot be achieved without the help of IPCEC. When eye care is seen with the perspective of achieving universal health coverage, following suggestions have been made for the policymakers. First and foremost, to provide quality eye care services according to population needs so as to improve service coverage and reduce inequalities. Secondly, to ensure that the cost of priority eye care interventions are included in the service package covered by prepaid pool financing. And thirdly, move towards IPCEC. So this further highlights the importance of implementing IPCEC to achieve universal health coverage. WHO has made strengthening integrated people-centered care central in its plan to achieve UHC. What this means is that the strength of a country's healthcare system is in part determined by the quality, affordability, and availability of its eye care services. As IPCEC is implemented in different countries, indicators will be required to monitor it. An ideal indicator would be one that would capture not only the magnitude of coverage, but also the effectiveness of coverage, thereby ensuring that people who need help services receive them with sufficient quality to produce the desired gain and vision. The indicator must also be able to measure the accessibility and quality of the services, and such indicators must be reported by population-based services on a regular basis. Among the list of indicators which have been defined to assess universal health coverage, 2 indicators pertain to eye care, and those include the effective coverage of refractive error and the effective coverage of cataract surgery. So essentially, these indicators could be used for monitoring the implementation of IPCEC. Key data points required in the calculation of effective coverage of cataract surgery are prevalent cases of operable cataract, prevalent cases of operated cataract, and prevalent cases of operated cataract and a good visual outcome. Similarly, the key data points required for calculation of effective coverage of refractive error are prevalent cases of vision impairment and blindness due to refractive error, prevalent cases of refractive error with spectacles or contact lenses, and prevalent cases of refractive error with spectacles or contact lenses, and a good visual outcome. More indicators need to be developed for monitoring the implementation of IPCEC. This will require strategic systemic planning to identify which information should be generated and from what sources. There is a need for defining input, output, and outcome indicators to monitor the quality of eye care, indicators to evaluate progress towards implementation, and global indicators menu for eye conditions and visual impairment that facilitates the selection of national indicators and promotes cross-country comparison. Thank you.
So thank you, Dr. Rachna Mill. That was a concise and insightful presentation on monitoring. So now that we are done with, now that we are done with all the presentations, I think we are now into the panel discussion and Q&A time. I would still encourage people to post questions. We right now have only a couple of questions that have been posted. So while we wait for more questions, let me kick off the discussion with a few questions to our panelists. Like I promised to introduce, we have with us 4 panelists. Dr. Aldiana Halim from Indonesia. It will be good if you can have your videos on and as spotted. Yeah. He's from the premier and the largest standalone, I think the only standalone eye hospital in the government of Indonesia in Bandung, which I had the good fortune of visiting several times and know it's an exceptional institution. And he is from there in the research department. And we have my good friend Inayat Hussain from Bangladesh, a well-known pediatric ophthalmologist, and also been part of the Ministry of Health, directing healthcare in general in Bangladesh. So I'm hoping that he will bring us a lot more integrated perspective, to this whole discussion, because many of us are kind of enclosed within ophthalmology. And we also have Dr. Praveen Vashisht from the Premier Institute in India, the RP Center, part of the AIMS. He heads the community eye health department and has been extremely active in many fronts, conducting over 30 odd RABs across India, doing resource mapping and been a rich resource for eye care in India. And then we have Shailesh Mishra, who again plays an important role in eye care in Nepal as the executive head of Nepal Netra Jyoti Sangh, which essentially coordinates most of the, I won't say all, but most of the NGO eye hospitals in Nepal. And they are the ones who provide possibly close to 80 to 90% of all eye care in Nepal. So we have an excellent panel to kind of go deeper into this topic. To start with, I'll pose a question. I have a question for each of the presentation, which I'll pose to the panelists. And then it will be good to also hear from the speaker's perspective as well. So with respect to the very first presentation on the overview of the IPCEC, I wanted to take a slightly different perspective to what Rohit had presented. Now, he mentioned risk factors and listed several that are modifiable and non-modifiable. However, you would recognize that he related all of them to the patient and the community, like age and lifestyle and so on. So in my thinking, I thought we should also recognize there's a parallel list of factors, that are provider-centric, not from the patient side, but from the provider side, which I think they are the ones which really lead to disparities, low coverage, and suboptimal outcomes. Because quality is largely in our hands. So these could be risk factors in one way of looking at it, not in a technical way. And they could be around design, how the care is designed and delivered. Now, how is it made available? How is it made? How is the financing done for this care? All of these are provider side factors, policies. So I just want to kind of throw it to the panelists to see how do we address this in the context of integrated people-centered eye care? So anyone can jump in. And at the end, I would like Rohit for you to round off. Yeah.
Okay.
Yes, Sailesh.
Yeah, thank you very much, Tulsi, for a very good, I think, issues, the risk factor. I think, yeah, you have already mentioned that the risk factor could be around the design, the resource availability, and other risk factor as well. And I agree that there are several factors at the provider ends that from the provider ends that lead to these disparities and low coverage and suboptimal outcomes as well. First, the good design of the eye care program is very important in every steps. For example, we do the outreach program, outreach activities in the community level, but we are not following the strategic pillar of the sustainable outreach program in many places, like for example, the calculating the magnitude of blindness there locally from the different surveys, and fixing the targets and the plans, resource management, community participation, community engagement, following the protocols, and calculating the case finding cost. After that, the fixing the parameters and benchmarks. In this way, another issues like while opening the vision center or the community eye care center or the primary eye care center, whatever we call it, we have to be evidence-based. We have to identify like where is the unmet needs, where is the vulnerable groups, size of the surroundings population, accessibility of this eye care center, we have to identify how we can close the referral and treatment loops. So like design plays an important role to address this disparity as well, because if we have a good design, many patients can have the accessibility. And also, like there is no tracking system of the referral patients to the secondary or tertiary eye hospital in many countries. We have seen that has also to be addressed. Apart from that, we have to create a shared vision aligning with the team. We have to also see the underutilization of the resources. Regarding the financing, we have to avail the rural like insurance system, or in Nepal we have the social security national health financing that can pull the risk as well. And for the human resource as well, we have to build a accountable team. We have to identify the population need as well, the quality of the training, and the policy and regulation, that is internal and external, is very important. I have seen that in many eye hospital, the management are not aware that the hospital should be disabled friendly, or there should be the female friendly environment in the hospital. So all these things, and market development, segmentation, these all things we have to put in focus, put in ahead to lower the disparities, low coverage, and some optimal outcomes.
Thank you, Sailesh. I think you really pushed the case for denominator-oriented planning and also patient-centric kind of approaches. Yeah, any other reflections on this, Inayat, Aldiana, or Praveen?
Yes, thank you.
Yes, Inayat.
Yes, please. Thank you, Dr. Khanna, for your nice presentation, cover all these things. So I'd like to mention something in the perspectives of Bangladesh. So basically, there should be strong government's political commitment should be there. In the country, we have for the eye care, there is an operation plan. It's indicate that government has strong political commitment for this one. And regarding policy formulation, I broadly point out the four things that should be covered for the ensure the IPC. One thing, we should cover that eye health should be in all policy and whole society approach. This should be done. I'm just talking about the broad headings. Another issue is that when we're designing our policy and formulating one, social determinant factor of the health should be addressed. Third issue is that regarding the concern of SDG, we must think of the leaving no one behind. Otherwise, we will not ensure the universal health coverage. And third thing, there should be the primary eye care should be integrated part of the primary health care. Other things I should mention regarding the financing. Financing should be appropriate, and it should be both from the government side, and also we should pull the money from the donor agencies and from the international agencies. And utilization of financing, key issue is the equity issues. In Bangladesh, actually, in the government service, the public health facilities, we did not ensure till now the equity. It is equal for all. And some other private hospital also, they do not ensure the equity. So not only the budget utilization, budget allocation, but proper utilization should be there as needed. Designing a phase, it should be community oriented. Community people should be well enough oriented. They should be know their health need, and they come to the facilities and like this. And there should be the proper monitoring of the quality care. So these are from our government side. Thank you very much.
Thank you, Inayat. Thank you. Anyone else want to jump in, or yes. Otherwise I would request Rohit to jump in. Yes, Aldiana, you have something to say.
Yeah. So one of the most challenging part in implementing integrated people-centered eye care is to encourage, at least in Indonesia, to encourage the policymakers to integrate the eye care into the health system. Even though the epidemiological evidence of visual impairment is available in some point, that the eye care is still a limited progression because of limited resources in the country health system, and it has to compete also with the other health demand. We are not talking about in the national level, because the eye care program should be implemented in a smaller area, like in the district level of the health system. So yeah, we have still a problem to integrate in the area of the province or in district levels. I think one of the easy way for policymaker to understand the problem of the visual impairment in the area is to convert or to analyze the economic impact. Sometimes when we provide the policymaker, especially in district level, that we have a problem that the policymaker is not familiar with the technical methodologies or with the complex implementation level in implementation level. So we are thinking how to. We are thinking also we have to include into the consideration to provide a way for the eye care activists, especially in province and district level, to also to analyze, maybe in the simple way, how the visual impairment impact the economic, because it's an easy way to deliver to the policymaker and to integrate the eye care program in the district health system.
Thank you.
Sir, I would like to mention few facts about India also, like key challenges in our country. It's mainly, even after all possible approach by government, still it is considered as a vertical program. And as far as the vision centers and primary eye care is concerned, there's some good initiative have been taken by the NGO sectors and also some private hospitals. But as far as the government of India is considered, there is definitely there is more need for integrating this private NGO sector with the government sector. As I can give an example, in 2004, when Vision 2020 India launched, and at that time we aimed that we should have 20,000 vision centers in India, and even now we say this around 4,000 vision centers. Clearly, lack in approach. Though we plan quite good, but in terms of implementation, we find such error difficulties. And of course, there is lack of coordination. As far as workforce is concerned, I believe the number of ophthalmologists is quite good. They're trained also, but here is main deficiency is in terms of paramedical ophthalmic assistant and optometrist, the huge lacunae of such human resource. And because of this, this refractive error program is being affected in our country. And we believe we have hardly 20% coverage against this, what we are thinking for universal eye health coverage for a country by 2030. Thank you.
Thank you, Praveen. Very quickly, can you respond, Rohit, because you have thought a lot about this particular topic?
Yeah, I think what everybody pointed out, first coming to Tulsiraj, your question actually, what you said was like very right. It's like we look from the patient side, but we don't look from the provider side. But most of the provider side also comes as a barriers to eye care, like poor surgery or poor outcome or distance or lack of, so they are to some extent covered in the barriers. But I think, but that's true. There are also modifiable and non-modifiable factors in both provider and patient side. So what coming to, I was just making notes of what Sailesh pointed out was, as you rightly said, it's very, he was looking at the denominator-oriented approach for providing integrated people-centered eye care. And I think what Praveen said was like basically lack of human resource and even considering eye care as a vertical program. So I think we have to define what does integration mean. I think we ourselves have to be clear. Yeah. What do we integrate? Where do we integrate? Where do we draw the boundary line? We cannot start into one specialty completely, jump from one specialty to other specialty. So where is our boundary line at primary level, secondary level, tertiary level? So that if we have that document, this is what we say and go to the government or policy makers. This is a document which we can say that eye care will be supporting, will integrating at each level of care in this manner. And probably the same thing should come from the other sectors also. So that would be something which I think we should come up with that guidelines rather than waiting for government to give a write a statement and say that eye care is integrated. That will not help us anyway. The moment we say the government announces that eye care is integral part of healthcare system. So then what next? So what do we do at primary level? What do we do at secondary level? So probably I think that is something which we need to come up with solution.
Sure.
Because we came up with solution for all our problems in the past. So we should come up with the solution also.
Yeah. Thanks, Rohit. Thanks, Rohit. I think I'd like to switch gears now. And I don't know, Russell, is it possible to highlight Dr. Sripriya? Because I think the next few minutes would be centered around her presentation.
Yes, we'll get her spotlight
if
for you.
Possible. Yeah. So I'll pose the question to the panelists. Again, feel free to jump in, anyone. So Dr. Sripriya, like I said earlier, possibly took the most comprehensive perspective to quality. She touched upon a lot of neglected elements like engaging people and communities, as well as coordination across sectors. So in all this, we recognize that quality is always a journey. It is not a goalpost. We continually, it's a direction basically. My question is, so there are some areas that we are not very familiar with, in the much bigger quality framework that Dr. Sripriya touched upon, things like community engagement, intersectoral coordination. So these are areas that we mention it, but then we're not very familiar with it. So my question to the enlightened panelists is that, how do we foster this? How do we make this happen? How do we make better community engagement and coordination happen? I'm sure within your own selves, you would have experience doing it. So I thought it'd be good to hear from you. And as in the past, I would like Dr. Sripriya to kind of give some closing comments in the end. Yeah. Yes, Shailesh. Yeah.
Yeah, thank you. I think this we already know that this maintaining quality in community eye care is not just confined to delivering the best visual outcomes, but it implies a lot of more aspects of the eye care services, and there are like different types of activities which can increase the quality of eye care services, and the community engagement as you have already mentioned, and the intersectoral coordination can play a great role for the same. So like for health sector in eye care to be truly people-centered, this first thing we have to know that the service users and the communities need to play an active role in the design and delivery of the healthcare services to ensure the local needs. So there should be the regular like kind of patient provider interaction that is very important, which can affect I think which can increase the quality of the eye care services as well. And the eye care professionals that are working in the community should always understand and take account of the community cultures. That is their perceptions, their experiences, their expectations in their interaction with the service users and the families. That can be the real reasons and the concerns that will influence the prevention, promotion, and treatment decisions as well. And ultimately, that will increase the quality of eye care services. And third one is the monitoring and evaluation framework, with the relevant indicators used for the strategic decision making. So like in Nepal, we are doing the social auditing of the program, of the hospital, of the eye care center as well, or the community people provide the feedback on the quality as well. So like we have to develop the ability at the community level to effectively combine the wisdom, knowledge, and concern of all those involved in the community, so that we can achieve like a greater and more sustainable process of continuous quality improvement. And forming partnership is very important to share the resources. In Nepal, where we have formed the partnership with the local government in many cases to establish the eye care center, and the people are getting their services at the local government, like the local government level as well. And we have to encourage the dialogue about the community concerns as well. So like there are a lot of activities we can start with the help of community engagement, which will ultimately improve the quality of eye care services, creating the awareness, planning and management of the sustainable and equitable eye care services, dissemination of information, social marketing, integration of the key components in the school child screening program, community-based rehabilitation program, primary eye care, training of primary health center. In Uganda itself, like there is the eye care facilities which is governed by the health unit management committee, and which have the community members directly contributing to the facility management, and that is like they have been empowered to co-design the quality improvement as well. So like there are a lot of activities with the help of community engagement and intersectoral coordination. We can ultimately improve the quality of eye care services. Thank you.
Thank you. Thank you. Inayat, I think you wanted to say something.
Yeah, yes. Thank you, sir. Again, it's a very nice presentation. So I like to mention here that from the beneficiary side, they should ensure the health literacy. If there is a health literacy, they have to be fine. So, we have the very good program of immunization. So the community service provider, they will have the twice a week visit to the villages where they arrange the courtyard visited. We call it the Uthan Boitok. So courtyard, that's why they ensure the health literacy of our beneficiaries. This is the one way. If we can integrate the eye care, it's not yet to integrated eye care there, so that will be one issue. So at the community level, again, we have the very good experience involving our local political leaders. When they are engaging the programs, they will ensure they know which people they are suffering from and others. So they will refer the patient to the nearby facilities. in the NGO sector, we have a good experience in the Bangladesh Diabetic Association. So they are now involving our religious leader in the every mosque in the Friday. They will ensure the diabetic screening camp, and we manage them to make the beneficiaries to refer to our nearby Upazila hospital. They are having the eye care check-in, eye check as part of their diabetes program. So this is one way if involve the religious leaders. During presentation, I have 2 or 3 observations. One thing is that how we address the multi-disability. So patient with eye disability and the other disability, how we ensure service. Or the patient with other disability, how they will be ensure service. That is the one area which should be ensured to ensure the universal health coverage. Other area is that, though it is very limited, but we should reduce the out-of-pocket expenditure. We find out reduce the out-of-pocket, how to minimize the out-of-pocket, reduce the out-of-pocket expenditure. I'll share 2 experience of our integration. In our ROP retinopathy of prematurity program, so it is led by the National Newborn Health Program. So I am the advisor of this program, but led by the National Newborn Health Program. So they are ruling it. Again, we are able to, in our IMC, Integrated Childhood Management Program, we enable to incorporate the eye care. So now earlier it was not, eye care is not there. Now at our Upazila hospital, this sub-district hospital, IMC center was there, and the service provider, those who are the paramedics and other, ask the patient, they have the eye problems and other, so that we can skin the cataract and the squint portion from the early part of their life. So these are our experience I'm sharing. Again, very good presentation, I think. Thank you very much.
So in the interest of time, can I request Sri Priya to say a few words, and then we move on to the next topic?
I think Dr. Shailesh and Inayat summarized the entire thing of how quality care has to be incorporated. To create quality care, we need to incorporate the community into the existing healthcare system, and we need to integrate the government with the politicians, with the religious centers, and with the NGOs. Unless it's a continuum, quality eye care cannot be delivered. That is from the delivery viewpoint. And we need to integrate our data entry has to be integrated with the health ministry, so that there is a the work that is done at the community level is reflected to the government, and it will facilitate the policy makers to decide on how to change the policy and evolve as we go.
Yeah. Thank you. I think in this space, we have a lot of work to do. I think we have the ideas, we have some proof of concept, but I think we'll need to make it more structured, as well as figure out how to scale this. Yeah. So I would like to switch gears, and if Divya can be spotlighted along with others. We all have gone now. Yeah. So what I want to ask the panelists is, I think in her presentation, she kind of proposed 2 important aspects. I think for the first time in eye care, when we operate at primary level, we really can design a denominator-driven eye care, based on needs, which Shailesh also mentioned earlier. Establish the needs for that community, and then see where we are, 20%, 40%. So we can really be evidence-driven towards coverage. And then also it makes it clear as to which are all the areas wherein we can do the integration. Because it becomes much more real at that level. So my question, very briefly to the panelists to think about is, now that we have this knowledge, now how can we leverage this to kind of both to scale, towards achieving universal eye health as well as the goals of the SDGs. So briefly, Shailesh, if you can respond to this. I know you had some preparation done. If you can be brief about it, then I'd like to hear about from Aldiana as well, from Indonesia.
Yeah, thank you, sir. I think just right from the presentation of Divya, we came to know that the primary eye care that is provided by the Vision Center in Nepal, we call Community Eye Care Center or the Primary Eye Care Center or the Eye Care Center. That is the essential the block for the prevention of blindness in all the communities. And without this primary eye care, only those individuals who present to the secondary and tertiary facilities will be diagnosed and treated, and little will be achieved in terms of prevention. However, we know that the scope of this primary eye care varies significantly throughout the regions. Like if you go to Africa, then is primary health workers are providing the primary eye care. If you go to UK, USA, and Australia, that is a developed country, the primary eye care is provided by the specialized personnel such as optometrists who are independent eye care service providers in these countries. In countries such as in India and in Nepal, in the government sector in India, the primary eye care is provided by the trained paramedical ophthalmic personnel, and in Nepal, the primary eye care is provided by the ophthalmic assistant. That is that we call the backbone of the eye care services in Nepal. And sometimes we call them the vision technicians as well in India. But this combined effort is very important, both for the vision center and the base on or the referral hospital to reduce the load of visual acuity. But these vision center, what we are talking about, or the primary eye care center or the eye care center, is like a static kind of things. In some areas, like in India, in some hospital, and in Nepal as well, of course, they are proactive, but these vision centers which we are establishing need to be proactive rather than reactive. Hence, like a deeper development and some rethinking of the model of this vision center need to be, I think that has to be remodeled to achieve this, to scale up the eye care services. So like some kind of innovative models of eye care can be introduced at the primary level, as per the local situation and the general healthcare system as well. But we all know that the integration of eye care into the primary health care is very important, but that has also raised some passionate debates in many places, like in where the public health care system is very weak, under-resourced, and inefficient. So nevertheless, there is the evidence that the integration of eye care at the primary healthcare can be effective through enhanced supervision and training of primary healthcare. It should be effective, and it will be effective. So there are a lot of strategy. But if we have a good primary eye care program in the country in line with integrated people-centered eye care, first there should be the good community participation, like we have seen in example in Nepal. As primary eye care, the vision center are locally based and have important links to the community. There is a scope of involving community members, like in health promotion, applying social marketing strategy for the behavioral change for the underserved and marginalized population. That is very important. We have to create the demand for that sector as well, and the announcement of special services. Like in these all things, community participation play a very good role, and reorientation of the model, that is which is integrated, and there is a referral pathway, that is very important. We have also seen some examples of training of female community health volunteers, Anganwadi workers in Nepal and India, and there are some eye hospital where we have mobilized the field worker who take vision in the community, as well as there is a door-to-door screening in some districts as well in Nepal. And also the using the technology is very important, like teleophthalmology, which has been used in India, can be replicated in the other countries as well. Like after that, the information technology, like the regular mobile text messages to strengthen the communication between the eye care patient and the providers. That is the additional ways to be introduced. And integrated services into the government healthcare system is very important. Intersectoral collaboration at the community level with the schools and the NCD program is also very important. And this for the long-term funding sustainability, that can be, we can have the coordination with the local government that can be funded for the operating cost of vision center or the eye care center or the primary eye care center for the long-term sustainability. So the concept of this integrated people-centered eye care as promoted in the World Report on Vision, that through some changes in the model and replicating the successful model can ensure the eye health services to reach those who need the services the most. So in this way, we can scale up these eye care center and vision center.
Thanks, Shailesh. Yeah. So in the interest of time, I think we just have less than 10 minutes now, 8 minutes before we have to come to a hard stop. So let me take one question from the audience as well, which is sort of related to this particular topic. I think Sonia Mavi has asked, how do we, when a woman accesses service, her concern is, how do we know they're receiving effective eye care? For example, she says, women access refractive services but do not receive spectacles due to whatever, cultural, financial, other barriers. Now, how do we deal with this? So Divya, Aldiana, if you have some insights, you may want to talk about this.
Yes, I think that's problem how we provide the services for the people in need is also the problem here in Indonesia. Indonesia has many islands and has a dispersed population. So we are talking about the people in the rural area, in the islands that who hard to access the eye care services. So we create some model of the service delivery in eye care, like in refractive error. So we are now start to implement to provide the ready-made glasses for the people in the rural or in the island for the spectacle, for example. And we have tried and we have researched the quality of life and the compliance for the school children, for example, in the rural area is good. So we are now start to implement how to share ready-made spectacle, especially for the people in the remote area. When we have still the problem to deliver the cataract surgery services. So we in remote areas, so we are now in Ministry of Health of Indonesia design like it's not a vision center, we call it a cataract center because the need of the cataract is so big here in Indonesia. So we are build a cataract center in the area for approximately 30,000 people. So create there and the services is mobile in one district, mobile in to 4 cataract center, and it operate one month in 1 week in a month. So we in whole month we can cover the whole district, I think.
Thank you. There's another question from Daniel Shaneholz asking, can vision rehabilitation be integrated into implementation of the SDG goals? And would it be optimal at primary, secondary, or tertiary level? It's kind of a design question. And I'm presuming by vision rehab, I think he is referring to more low vision services. So what do you think would be feasible at primary, secondary, and tertiary level? Yeah.
I'm responding it.
Yeah.
Yes, thank you very much. Actually, I earlier mentioned that this is a common problem where the patient with disability, multi-disability or disability, how to address that. So actually, it is not possible to have the low vision service diagnosis and other things in the primary level. So I think it should be somehow in the tertiary level or at least in the secondary level. But the regular periodic checkups and the equipments and other things, they should be ensured. It should be their doorsteps, I think.
Yeah. So I think this is where the integration really comes in. I think certainly at the primary level, you can do case finding, identify people who would benefit from rehab. Now, while the rehab itself would happen in tertiary level, because of low numbers and the expertise required. Again, the compliance and follow through can again go to secondary or tertiary level. So I think this is a beautiful case now where integration can help a lot. And before we wind up, we have another 3 minutes. I just want to briefly touch upon the monitoring, where Dr. Rachna Mil talked about the revised thresholds for the cataract and refractive errors, where the threshold is now brought down to 612. So I just want to very quickly check with the panelists. Now, how do we operationalize this? Because till now we have been very used to referring patients either at finger counting or 3/60 for cataract surgery, to referring people who are below 612. So how do we engineer this kind of? It almost seems like a mind shift change. How do we make this happen?
I'm responding one. Actually, I do not know whether this is ambitious was not, but I am thinking of this, the people, the living now behind who are not coming to our facilities. I'm thinking that there should be a trained community health worker. They should visit house to house. And from there, they should, with the laptops and other things, they should capture the data, those who are in need of, and ensure their presence at the primary centers. And that ensuring should be with the community leaders or others, those who have needed facilities. Maybe they have the other accessibility issues that should be addressed. And by this way, we ensure them to be in the primary healthcare centers. And there will be the process level intervention should be at the low cost and high impact and the good quality ones. If you go for the output level, so output level, the coverage will be, we ensure the more. So these are the way we can ensure it. Thank you very much.
Any last few words, Dr. Rachna, literally 20, 30 seconds before we wrap up.
Yes, so indicators, I think, are very difficult to set up for this kind of an integrated service, because we need to see, we need to actually monitor the input as well as the output, and we have to make indicators accordingly. And like, for example, the ones that I had put in the presentation, the ones that are already used in UHC, Universal Health Coverage, to assess universal health coverage, where they see the prevalence of the unmet need of refraction and cataract, and then of course they see the prevalence of the met need in terms of quality, where they say what is the vision of the patients who've got refractive correction or cataract surgery. So similar ones need to be developed for other areas of glaucoma and also diabetic retinopathy, and I'm sure they'll come up, but it will need more deliberation because they are not as easy to measure as maybe an outcome of cataract surgery or refractive correction. So it needs more deliberation by the people involved in the integration.
Good, right. Good. Thank you. I think that's a good way of also summarizing this workshop, because I think a true learning happens when we have lots of unanswered questions. And that's precisely what this deliberation for 90 minutes has come up. I think at one level, rich content was brought in. And I think the content itself challenged us on many fronts on what needs to be done. So I think we are on a journey, and I also believe we are on the right path in kind of discovering and codifying what integrated, people-centered eye care should be. And I think deliberations of this kind, going back and reflecting on it and then coming back in other forums, I think is what will lead us to in that direction. And I'm sure each one of us, both at institution level, at national level, policies like Dr. Inayat is positioned to do, to kind of bring in this understanding into practice and policies, I think will happen. And hopefully in the coming times, we would have better insight and deeper understanding of really making this integrated people-centered eye care a reality. So I want to thank the 4 excellent presentations, the presenters, as well as the deep insights that came clearly from experience, that was shared by the panelists, and also for the various participants for raising some of the questions. I know some got answered offline, but again, we want to thank you for your participation. Thank you all.